Wow, thank you so much for that introduction. I feel quite overwhelmed, thank you. And thank you hugely for the invite as well. I'm very, very grateful to be invited to come. I love your country already. I've only been here a day. I don't know whether it's morning, evening or night, but it's lovely. My background, as already said, I'm a clinical nurse specialist. In the UK, we've got a standard that every man diagnosed with cancer has a clinical nurse specialist attached to him, who's the key worker, who's somebody that guides them through their treatment. We do lots of different roles. Some of us are about support and education. Some of us run clinics. As we said, I'm a non-medical prescriber, so I see patients in clinic. I can prescribe chemotherapy, oral therapies like abiraterone and enzalutamide. But principally, my role, as I see it, is around support, and I hope we can talk a bit about that today. So the agenda I put together, and as I said, I'm very happy to sway this, is a little bit about setting the scene about prostate cancer. I'm going to talk a bit about what we call survivorship and unmet needs of men with advanced prostate cancer, and a bit about support and what do we mean by that, and what do we all know. A bit about testosterone, what it is, why it's important, and hormone therapy, and how to live well on hormone therapy, and a bit about other issues for men with advanced prostate cancer in their families, and a sum up about empowerment, because hopefully that will be the word of the day. So prostate cancer is the fourth most common cancer worldwide, and the second most common male cancer. In the UK, it's the most common male cancer, and in the UK, it's a quarter of men diagnosed with cancer will be diagnosed with prostate cancer. Where I work at St Thomas's, which is in South London, we've got the highest incidence of prostate cancer in the entire country, and as such, we're incredibly busy. In my clinical role, I deal with men with advanced prostate cancer. We see around, just in outpatients, we see around 200 men a week with advanced prostate cancer. And on top of that, we've got men on the wards having chemotherapy, radiotherapy, etc. So we're fairly busy. Some of the terminology we use, again, I'm sure you're familiar with this, but when we talk about any cancer, we use a TNM staging system. The T is for tumour, and we grade prostate cancer grade 1 to 4. 1 is where it's inside the prostate and unable to be detected except by biopsy or quite often just by chance. T2 is where it's also inside the prostate, but you can feel it in digital rectal examinations. That's where you get the finger at the back passage. T3 is where it's started to break through the capsule. And T3B is where it's in the seminal vesicles, which is, I'm not sure if I've got a light on here. Don't want to break anything. Okay, so T3A is where it comes to the capsule, and T3B where it comes to the seminal vesicles. And then T4 is where it's invading other adjacent organs. Nodes, so your lymphatic system is a network through your whole body which fights infection. It's an incredibly important system. Your tonsils are part of your lymphatic system, your spleen is, and also lots of nodes or little areas through the body where cells collect. If prostate cancer spreads to these nodes, we call it N0, N1, depending on where they are. And N1 is what we call nodal spread. And then metastases is where it goes to other parts of the body. In prostate cancer, the most common place is bone, but it can go to lymph nodes, it can go to any organ, potentially, but most of the time we see it in bone. T, 1, 2, 3, 4, N1 or 0, and M1, 0 or 1. And that tells us what we need to know about where the cancer is and where it's gone so far. Does that make sense? Good. Because nobody wants to be known as a load of letters and numbers, we also use other terminology which makes it a little bit easier to understand. Localised prostate cancer is where it's just in the prostate, so it hasn't spread anywhere else. And if you're diagnosed with localised prostate cancer, often it's curable. Locally advanced prostate cancer can also be curable, and that's where it's just started to spread outside, where I showed you in the seminal vesicles or just outside the prostate, or sometimes in the lymph nodes around the prostate. And then advanced prostate cancer, which is the guys I get involved with, is when prostate cancer spread from the prostate to other parts of the body. Normally it moves to the blood system or the lymphatic system, and then it settles somewhere and grows. And then we can describe it in lots of ways. We might say metastatic, we might say advanced, we might call it secondaries or METs. The important thing is it's prostate cancer wherever it is in the body. So if you've got prostate cancer in the bone, it's not bone cancer, it's still prostate cancer. And that's really important when you think about treatments, because a lot of our treatments in advanced prostate cancer are whole body treatments, and they'll treat your cancer everywhere. So I quite like this map because it's a heat map which is easy to understand. There's a lot of variation in where people get prostate cancer, and there's me at the top in orange and there's you down the bottom in orange. So, or top and bottom the other way around if I'm the one standing on my head. And it's an interesting map because what you'll see is the areas where there's a high incidence of prostate cancer are generally richer areas. And there's lots of reasons for this. There's lots of factors which influence both incidence, which is the number of people diagnosed, and mortality, which is the number of people that die from a condition. And it's not always as simple. It's not always about good treatment. Sometimes it can be quite weird statistical anomalies as well. So you can get things called overdiagnosis, and that all sounds a bit weird to anyone who's actually got, how can you know too much about having cancer? Well, sometimes if you get diagnosed with very early low-grade prostate cancers, they may never cause you a problem through your lifetime, but if you get diagnosed with them early, you will, obviously that will influence the incidence of a prostate cancer where you are. And you'll see that a lot in kind of North America, those sort of countries. There's also the impact of underdiagnosis and late presentation. Late presentation often presents in advanced prostate cancer. And the big thing is about life expectancies. If you live in a region where life expectancy is 40 or 50 for a man, your prostate incidence isn't going to be very high because men don't live long enough to get it. So what might look in some places like, oh great, they don't get much prostate cancer, actually means it's just unfortunately that their population doesn't live very long and so they don't get it. So there's lots of ways of looking at incidence. It's not always quite as often as it looks. And sometimes there's a good reason. It could be that you live in a country where you've got great treatments, and it could just be that we're treating it better, and that's why your mortality rates are better. What we do know, though, is that so incidence is how many people get diagnosed, and prevalence is how many people have got it at a certain time. And we know that globally, more people are being diagnosed, but crucially, more people are living with prostate cancer. And again, that's maybe due to better treatments, but also early diagnosis. And you can see the predictions there. And for me, probably the important one is this one. The number of men that are going to be living with prostate cancer and what we're going to do to support these men. And particularly in a climate where nurse recruitment and nurse retention globally is a huge issue at the moment. So that was our kind of overview, and I just wanted to make sure we are all on the same page and we all understand it, and also to give you a chance to tune into my accent. So hopefully we're all there. So the first step is about survivorship, unmet needs and support, and what do we know? So survivorship, is that a term that you're familiar with? Do people talk about survivorship? No, not really? Okay. So survivorship's a buzzword without a shadow of a doubt, but it's also really important. So survivorship is also known as living with and beyond cancer. And it basically comes from a whole body of work looking at people with all sorts of cancers. And some of this work found that around 1 in 3 cancer survivors were still having side effects which was affecting their quality of life. And this is really important for us as health professionals to know, because if you look at a lot of our research and our studies, etc., what we're interested in is survival, cure, outcomes. And of course, that's really important. But what people are actually living with and left with is also really important. And survivorship is about shifting the focus a little bit onto how is it for you and what's happening with you. So one part of survivorship is around what are we leaving you, effects of treatment, and that might be incontinence after prostate surgery, it might be erection problems or sexual dysfunction after hormone therapy, but it's something that you're left with after treatment. The other part of survivorship is when they looked at studies and spoke to patients, lots of people felt that even if you've come through your treatment and you've been given your all clear and you've been discharged, lots of people in the studies said that they're actually left with a sense of abandonment. It was like, well, there's all the kind of fuss and stuff that goes on when you're being seen regularly, and the confidence that brings you to know that somebody's looking after your cancer, and then suddenly you're on your own. And lots of people said that was a really, really scary time for them. Lots of people were delighted, but lots of people said that it was a scary time. What if it comes back? What am I looking out for? I didn't have any symptoms in the beginning. How on earth am I going to know if I've got it again now? All those feelings can be quite intrusive sometimes. So we know those two needs exist. Again, not for everyone, but for some people. We also know we've got more and more people living with and beyond cancer. And we've got very traditional models at the moment, and most of us have been through systems where you go in, you sit in a waiting room, and then you go in and you see your doctor, and then you have a one-to-one conversation, and then you leave again. But when you've got more and more patients and less health professionals, and certainly with you guys also there's a distance issue as well, that's not necessarily sustainable. And that traditional follow-up model isn't always the best thing when we're talking about effects. And I'm sure lots of us have been in the position where you would go into a consultation, and for you guys, often when you go in, it may well be that all that's on your mind is, what's my PSA? What's my PSA? Is it okay? Is it still undetectable? Has it gone up? Has it got down, etc.? And when you get that news, it may not be the best time when we're talking about other things as well, because if it's good news, I'm sure you want to run and celebrate, and if it's bad news, you're not hearing anything. So that traditional model isn't always the best way that we can, as professionals, can empower and help you guys as well. So that's survivorship in a nutshell. So it sort of beholds on us, well, that's great. So we know that from the research, but what are these unmet needs? What are our patients, what are we not meeting for them? And there's lots of ways to kind of work this out. And I think we've been guilty in the past of assuming, of thinking, well, I know my patients and I've been doing this for donkey's years and I know what's going on, but actually that's not a great way to do it. So we use a variety of ways, and this is the things that I've found the most helpful. So the first thing we use in the UK, and I'm not sure whether it's reached you guys yet, is we call them H&A's, Holistic Needs Assessment. And what they basically are is a questionnaire. And you might say, well, great, so what? It doesn't matter. The difference with this, it's a self-assessment checklist. And it's basically about your concerns, and it's nothing to do with the particular cancer you've got. So you'd get the same checklist whether you have prostate cancer, breast cancer, lung cancer. But what it asks you is, tell us about the things that are important to you. Tell us about your physical concerns. Tell us about your practical concerns. We know cancer is expensive business. We know that if you're self-employed, for example, having a diagnosis of cancer and the treatment can be the difference between paying your bills and not paying your bills. So do you have any caring responsibilities? Are you struggling with looking after relatives, children, etc., while you're also trying to look after yourself? Are you having problems with work? Are your work being supportive? Have you lost your job because of this? Are you in education? Is that also an issue? Transport, housework, shopping, all those practical things that traditionally we probably haven't asked you about. We also ask about family relationships and concerns, emotional concerns, and that can be anything from difficulty making plans, symptoms of low mood, like loss of interest in activities. It could be things like guilt, hopelessness, loneliness. We also ask about spiritual and religious things, and also just generally your lifestyle and your information needs. Do you want some information about support groups, complementary therapies, diet and nutrition, and all these other things? And we also ask you to do a concern score. Just globally tell us on a scale of 1 to 10, what level of concern have you felt? Now, when this first came in, as a group of nurses, we're not a fan of change generally, and we're like, oh, this is ridiculous, we don't need a checklist, we do this already. But we went with it and we tried it. You do your checklist, then you either do it on paper or iPad or a code that you can complete online at home. Your checklist is then discussed with you. We then make a care plan based on the concerns you've got, and that's then shared with your GP or any other health professional. So anyone, in theory, anyone looking after you will know what we're planning to do. That's a theory. In the true spirit of the NHS in the UK, it arrived with no resource, and it arrived with a diktat, you will do it. I don't mind how, but just let us know when it's done. So it's been 5-6 years of trying to embed it into practice, just because it's quite hard to do on top of everything else. But we're doing okay. In my organisation, about 80% of patients get one of these assessments and care plan within a month of being diagnosed, which is pretty good from 0. So we were all quite blasé about, well, we're doing it already. Our patients don't have any concerns because we're fabulous. Well, here's our data, a little bit of a kick in the teeth and a real humbling experience. So this is our patients from January 16 to September 19. Now, bear in mind, we've got about 1,350 responses. From the first couple of years, we weren't doing very many, so this doesn't represent all our patients. But actually, what our patients told us was they absolutely did have concerns that weren't being met at the moment, despite us thinking we were doing well. And actually, despite us coming pretty top in lots of metrics, like our cancer patient experience study. So our patients said, actually, that before treatment, they were really worried about sex, about passing urine. They were generally globally worried about having cancer. They were tired, they had sleep problems. They were worried about the future. There was some experiencing sadness and depression, and some had pain. And then after treatment, most common concern was urine, and then it went back to sex, fatigue, etc., as you can see. So this is pretty good. So 750 nearly patients before treatment had concerns, and about 600 afterwards. So, you know, it really was a big learning for us, and also it very much told us that we need to engage in this survivorship malarkey, because it's real, and we're obviously not doing everything we can for our patients. So we looked specifically, this is the androgen deprivation, the hormone therapy data. So again, before treatment, our patients were worried, tired, and there was a real issue around thinking about the future, worry, fear, anxiety, uncertainty, depression, worries about the partner, etc. So we've got some, you know, reasonable data now about what our patients' unmet needs are. We also look at evidence. So we're very blessed with some fantastic nurse researchers here and in Australia and New Zealand. And there's this one paper that I love. It's by a lady called Catherine Patterson, who was working in Scotland. She's now in Australia as a professor. And she did a really nice paper, a qualitative paper, asking men with locally advanced and metastatic prostate cancer on hormone treatment, what are your needs? And I've grouped them into these columns. So the physical one, the sort of things that men were reporting were physical problems like pain, but also all those hormone-related ones, the hot flushes, the weight gain, the fatigue, then things like urinary symptoms. There was lots around patient-clinician communication. So there was concerns around how news was delivered, how bad news was given. There was concerns about support and information, what we were giving people. Lots of issues around access to a nurse, despite the fact all patients should have that. There was some around our perceived lack of empathy and compassion, and also communication with GPs. And then when we got onto the psychological, it was really interesting, and I think this is probably where we do least well. So existential concerns around death and dying, which I think we all get once we hear that word cancer. It doesn't matter if it's appended with I can cure you or we can do something about it. We all think about it. Lots of issues around prognosis and uncertainty, and a huge worry around fear of progression. Then we've got all the intimacy and sexual issues, libido, masculinity, and then what we call health systems information. So this is around navigating your way around a system, how hard it is to get scans, know what's going on, communicate with the people you need to communicate, and just the practicalities of having to deal with this huge, cumbersome health system. So for me, this was a lovely piece of work, because none of this was a surprise, it all resonated, and it also tied in with our holistic needs assessment. On top of that, we also do focus groups. We do an awful lot of focus groups. We get men in a room and we just ask them, what's going on for you? Tell us about this, tell us about that. And a bit later, I'll show you the results of one of the focus groups we did around the unmet needs for men with metastatic prostate cancer. We use positive feedback, we use complaints, and we also use our own experience. We use what we hear in things. And from that, we can map some certain needs where we can focus interventions, because if you don't know what the needs are, how can you possibly start focusing interventions? So the sort of things that we need to really be thinking about is presenting symptoms, but lots around anxiety, communication, decision support, that whole navigation, financial concerns, and all those existential things, side effect management and intimacy. And there's also something around advanced care planning. And that's for all of us. I'm passionate about this, and I nag my son, who's 28 and in fine health, wills, writing down what you want to happen when you're incapacitated. All those things are incredibly important for all of us to do. Never leave it too late. So when you start thinking about ideas in action, how do you live well with prostate cancer? How do you put that survivorship agenda into practice? A lot of the data and a lot of the papers around empowerment and self-management, and that's brilliant. When you've got a highly motivated, mobile, interested group, that's fantastic. It's great to move away from paternalism. You know, nothing about me without me. You know, we want you to be involved with every decision. We want to stop telling you what to do. We want to start working with you to decide what to do. We want to really work on self-efficacy, which is about you managing your issues yourself with support. We know a lot about health benefits of activity and engagement. And we also know that people need information to make change. So absolutely that's our role, to make sure that you get the information you need. So that empowerment and self-management is absolutely key. But what's sometimes forgotten is the more holistic side of it, the fact that not everybody's in the position to be able to get these things. Where I work, for example, lots of my patients are socially isolated, lots are non-English speaking. I think we have something like 36 languages spoken in our boroughs. There's a huge lack of health literacy, so lots of people don't understand how the health system works, they don't understand about cancer, about health issues. There's lots of belief systems that aren't necessarily engaged with ours, a huge lack of confidence and motivation, and a massive fear of the unknown. So whilst we definitely want to move people to a position of empowerment, for some people that's a step too far, and we also need to provide this holistic support as well. But it's also how you do it. Who needs it, where do you do it, when do you do it? And there's lots of ways to provide this as a clinical nurse specialist. We do a lot of one-to-one things, so face-to-face consultations, lots of peer support as well. We run a great support group at my work, not quite as many people as here, but you know, it's a very supportive, lovely, tight community. And family, of course, family support is incredible. So lots of your support you'll get from one-to-one from other people. You might get it remotely, it might be telehealth, it might be phone, you phoning us phoning you, email, lots of intimate support groups and forums, etc. Or it could be groups like today, seminars, including web-based seminars and other support-based activities. And I'm going to particularly concentrate on that last group today because it's something that I really passionately believe in. It's something we've done a lot of work on. I think the really important message, though, is that there are pros and cons to every approach. It depends on the man, it depends on the healthcare environment that you find yourself in, it depends on resources. You know, with 200 men a week going through our outpatient department and one nurse to look after them, I can't offer everyone an hour appointment. So, you know, you have to also sort of make the best choices with those resources you've got. I think really importantly, it will vary from man to man and from occasion to occasion, and it's incredibly important to be flexible. And what we really try and do, and again, let me know how it would work for you, is to provide a choice and a combination of these things, because it may be that on one day one thing works and one doesn't. So it's about offering flexibility and a range of resources that people can tap into. So our first step was just a little bit of an introduction to survivorship and unmet needs and what do we all know. And I can't say it strong enough, you know what you need. Everything I've talked about, the holistic needs assessment, the evidence, the focus groups, the complaints, the compliments, the clinician's experience, all comes from you guys, from patients. And it's really important to remember that you have the power and you have the information. You need to help us get that. And if anyone's not interested, then they're not the right person for you. It's really important they are interested. I think there are definitely some common themes, especially around communication and definitely around side effect management for men with advanced prostate cancer. And I, as a healthcare professional, I'm definitely very aware that the number of men needing our support is increasing. And it's my job to understand the needs and facilitate. So facilitate self-management without a shadow of a doubt and get away from that paternal model, but also to be able to provide more hands-on support for those that aren't ready to kind of be self-empowered. And there are loads of ways to do this, and we'll examine some of them. And I'd love to know what's worked for you as well. So if we're going to talk about advanced prostate cancer, we're going to talk about hormone therapy, we have to start with testosterone. It's really important. And some of the biggest information issues my patients have is not understanding why we're doing what we're doing. And I think it's absolutely essential that you understand what we're doing to you. So testosterone is a hormone. It's found in men, but also women. In men, it's mostly produced in the testes. We also produce, or you also produce some in the adrenal glands, which are sat on top of the kidneys. Think about testosterone. People often think about testosterone in the fetus, so it's what makes boys boys. And you often talk about testosterone in terms of adolescence, so it's what turns boys into men. So it's a hormone that makes the testicles drop, the penis get bigger, the voice deepen, that traditional male shape coming. So it's really important for all those secondary characteristics. It's also really important for sex drive and sperm production, etc. So we kind of think of it as the hormone that really gives men their oomph. It's about drive, it's about overall health and well-being. So it's an incredibly important hormone. It affects nearly every part of the body. And I always introduce, this is a typical prostate patient where I work. They all look like this, every single one of them. That's not true. So what we know about testosterone is it affects you from head to toe. Testosterone is important for skin, for hair growth, for your skin moisture, for oil in your skin. It's important for your sex organs, for penile growth, for sperm production, for prostate growth. It's incredibly important for bone. Bone isn't just a static thing. Bone grows and develops constantly, and testosterone is needed to make that happen. Really important for brain. Everyone thinks that, men think there, but they think there as well. And it's important for libido, for mind, for mood. Massively important for muscle. So your male body, muscly hair and narrow through the hips, that's testosterone that makes that fat distribution and that muscle distribution happen. Really important for bone marrow and kidneys. So it stimulates EPO and also stimulates stem cells, both of which are really important for red blood cells. So you can see from top to toe, testosterone is really important. So the obvious question is, why on earth would you want to get rid of it? I mean, it's ridiculous when it's such an important hormone. Testosterone is important for the prostate generally. So in a healthy prostate, every prostate cell has a little area on it called a receptor. And the receptors are like little locks, and testosterone is a key. So if you can imagine you've got your prostate cell, the testosterone will attach itself to the area, and that's what triggers the prostate cell to reproduce. So all through your life, testosterone is working with your prostate to make the prostate cells healthy and grow, which is brilliant. It works really well. It's a stimulus to make prostate cells grow and reproduce healthily. The problem is it also stimulates unhealthy cells. So if your prostate cells have got cancer, your testosterone is also going to be stimulating those, and they're going to start growing and reproducing and start to potentially spread. And that's why testosterone is important for men with prostate cancer. Look at the diagram. So you've got your prostate cancer cell, and that blue area, AR, is androgen receptor. So that's your little lock. And your testosterone in your blood will find that cell and attach itself, and then your prostate cancer cells will grow. And that's what causes prostate cancer cells to get bigger, for the cells to develop in the prostate, and then eventually, potentially, to break away. So if we want that to stop, if we want to put a halt to that, there are two ways of doing it. The first one is we can give you a drug to block the receptor so that the testosterone cells can't get there, and it just blocks it. So the testosterone cells try and get in there, they can't do it, so then they go away again, and your cancer cell won't grow. Or we can just get rid of the testosterone, and there's nothing there to bind, and so your prostate cancer won't grow and it will go into remission. And those are two incredibly effective ways of stopping the cancer spreading and growing. We've known about this since the 40s. Two scientists developed this theory using estrogens and using operations. So to sum up again, what's hormone and androgen therapy? So prostate cancer depends on testosterone to grow. If testosterone either can't reach the cell or isn't there, then the cancer stops growing and stops spreading. It's not a cure, and it's really important to say that. A hormone therapy on its own won't get rid of prostate cancer, but it will stop it and it will put it into a kind of remission. And importantly, it's also used with radiotherapy in localized disease to shrink the prostate and make it sensitive. And lots of you guys, I know some of the people I've talked to today will have had hormone radiotherapy, where you have a course of hormone therapy with your radiotherapy, and that's why it's better to have a small target, because the smaller the target, the less the damage to the other tissues, and it also sensitizes it and makes it work better. Now, these are the injections we use in the UK. Some of them, like Zoladex, will be familiar. We use Prostate with the Luperilin, and we also use some other ones, like Decapeptyl, which is an immediate suppressant. We normally give them in the form of injections. You can have an operation to remove part of the testes as well, which is what we used to do before we had the injections. I started work in my post I'm in now in 2008, 11 years ago. And when I started there, this was the treatments that we had for advanced prostate cancer. Men would start on ADT, androgen deprivation therapy, hormone therapy. They'd start on hormone therapy. They'd carry on taking it until they progressed, so their PSA started going up or there were some changes on scan. We then add in an anti-androgen tablet to block, and then they'd progress again at some point, and then we'd give them chemotherapy if they are well enough. And then we'd use other things like stilbestrol, which is an estrogen, or steroids, etc. And underneath, we were managing side effects and bone and trials, etc. And that's how I came into it. Now, the landscape has changed out of all recognition. I can go on holiday for 2 weeks and come back and we're doing things differently. We've had amazing investment in research for advanced prostate cancer. Now, if you're diagnosed with advanced prostate cancer, you'll start on hormone therapy. Again, it's our foundation treatment, but you may well be offered chemotherapy or radiotherapy along with it, or even abiraterone. We can't give that at the UK and the NHS at the moment, but it is licensed for that use. Then we've got abiraterone and enzalutamide. We've got chemotherapy again if you haven't had it already. We've got another chemotherapy called cabazitaxel. We've got radium-223. We've got lots of trials going on at the moment, lots around immunotherapy and genetics and etc. So we've got a completely different landscape, and every one of these extra things gives extra time. So we're in a position now where men are living, thank God, much longer. But they're living much longer on hormone therapy, and hormone therapy has side effects. So it becomes even more important, whilst we're looking again about survivorship. All these things are fantastic in terms of being very good treatments to extend life and to keep people living longer, but we also want to concentrate on living well. And it's really important to tackle all those things about living with cancer and the side effects, etc., to make sure that you get the best possible quality of life as well as quantity. So we've got more treatments, better treatments, but hormone therapy is that foundation treatment. So in my view, living well has to involve a proactive approach to living well with hormone therapies. It's no good to keep waiting for people to tell us there's a problem. We need to be proactive about it. And in my practice, we try really hard to make sure that men are equipped with all the knowledge they need when they go onto hormone therapy, so that they can start making some really good changes if necessary, things like exercise, for example, which will improve their experience of their hormone therapy. There are two categories of side effects for men using hormone therapy: the seen and the unseen. And I'm going to start with the unseen. Not having testosterone changes some metabolic processes. Not having testosterone increases the risk of osteoporosis, which is bone thinning. It increases your risk of fracture, and fracture brings all manner of problems, particularly as we get older. It makes you put on weight. Lots of you will have experienced this. You tend to put on weight around the middle. And yeah, I'm just seeing some nods. I'm 50, I know what it feels like. You risk developing insulin resistance, so it can change the way your body metabolises insulin as well. So when you're on hormone therapy, particularly on long-term hormone therapy, it increases your risk of cardiovascular disease, diabetes and osteoporosis. So it's really important to know that up front, because if you know it up front, you can start to mitigate some of that. It's not absolute, it's about risk. And if you know you're at high risk, you can potentially do something about it. Osteoporosis, so you know I said about bone not being a solid thing. A normal bone is it looks like a sponge, it's a matrix. And osteoporosis, it's a much holy matrix, so which makes the bone brittler and weaker and more likely to fracture. There's no symptoms of osteoporosis, you don't feel it until something bad happens. So what can I do? Well, there's loads of things. One of the great things about this is there are lots of lifestyle measures, things completely and utterly in your control that you can do if you're on hormone therapy to start mitigating some of those excess risks. We know that diet, exercise, weight control, smoking and alcohol all have an effect on all of those things. So for diet, a diet high in calcium and vitamin D and exposure to sunshine will help strengthen your bones, as will exercise. resistance exercise for bones, so anything that puts pressure through your joints and your bones is incredibly important. That will help bone turnover, which will reduce your chance of getting osteoporosis. A healthy body mass, not smoking, and moderate alcohol. And for cardiovascular disease, again, diet, low saturated fats, high fibre, and aerobic exercise. So you can see by making some simple life changes, you can actually mitigate some of those not unseen effects. And we'll talk more about how to do that later. I know some of you have had experience of hormone therapy. Does anyone feel comfortable to kind of shout out some of the side effects that you might have actually noticed on hormone therapy?
No.
So I've got hot flushes, weight gain, and none. Someone's showing off at the back.
Developing breasts.
Yeah, absolutely. So developing breast tissue, we call it gynecomastia. So it can be either painless or painful. When it's painful, it tends to be really sensitive around the nipples. So it can be something that it feels unpleasant, but also can, be embarrassing. Anything else anyone wants to own up to?
I'd just like to say that the only life-changing side effect is that I'm still here.
Oh, that's lovely. I am so stealing that quote. Okay. Yeah. And do you know what you said actually really resonates, because probably a huge part of my working week is talking to men about their side effects. And one huge thing is around how you kind of frame it, because whatever you're feeling physically, your mental attitude to it is going to be really important. And someone mentioned hot flushes. So hot flush, about 80% of men that are on hormone therapy will get hot flushes. And, as a woman of a certain age, I'm not a stranger to a hot flush myself. They're unpleasant, they're annoying, etc. I was doing a support group with my guys, and we were talking about hot flushes. And one chap had really struggled to get to the group, but he wanted to come because we were talking about hormone therapy. He got really upset, saying, he was getting 12 hot flushes a day. It was keeping him up at night. He wasn't going out anymore. He'd stopped seeing his friends. He was too embarrassed to travel on the bus because when he got hot flush, he poured sweat. And, was really upset. And another guy that was with us said, I know how you feel, I get them as well, but for me, they're a sign that I'm on treatment and it's working. So I think that kind of positive mental attitude about things can change. It may not change what's happening, but it can change the way you feel about it. So I think, thank you for that, and I'm stealing your quote next time. So these are some of the common things that men notice when they're on hormone therapy. So hot flushes, as I said, one of the main ones. I think if I had to rank the two main things that men come and see me about, it would be hot flushes and sex, without a shadow of a doubt. What hormone therapy tends to do to your sex drive is knock it into the grass. It can also have an effect on erections as well, but libido and sex drive is the main thing it affects. Anyone noticed any body hair loss? So you don't tend to lose it on your head. You tend to lose it sort of arms, legs, chest. Yeah, it's a thing we never tell you about because we never remember, but it often happens. Tiredness is another big one. Someone I was talking to at the break was talking about their fatigue and tiredness on hormone therapy. Anybody want to admit to mood swings? Any of the partners in the room want to tell us about? Yeah. Someone lady there putting her husband's hand up. Yeah, and that's been really difficult. It's that feeling of ups and downs. What men often say is that the highs are high and the lows are low. So you can often be a bit more tearful than usual and just feel more sensitive, more attuned to things, which can be difficult. And then the last one, memory issues. Anyone notice that? More forgetful or more difficult to concentrate? No. Yeah, some people say that it just makes them feel foggy, just not quite, it just don't feel it. They lose their sharpness a little bit. And again, that can be really tough. And I always say, hormone therapy, we use it so much. I think as urologists or oncologists or specialist nurses, we can become quite blasé about it. But it can be quite a life-changing treatment. And again, that's why I think it's incredibly important that we take some time to make sure that you're living your best life when you're on it. So what we often, when people come to see me, quite often what they want is a fix. So when I've got this problem, how can I get rid of it? How can I deal with it? How can you make it go away? And there are without a doubt some things that we can offer in terms of fixes or ways to help. So what the metabolic effects I talked to you about, so the risk of diabetes, of heart disease, of the weight gain, etc. Good old-fashioned exercise and diet is incredibly important. Now, exercise is important, full stop. We've got more and more and more evidence showing that vigorous exercise is important to reduce your cancer risk, the risk of it coming back, etc. We know that exercise is good for you, but it's particularly good if you're on hormone therapy because of the risk to your bones and the risk to your heart. If you've already got low bone density, and you'll find that out with a DEXA scan, ask if you've not had one. We can give you supplements, so calcium and vitamin D, advise you to make the most of sunshine when you see it, obviously remembering about the risk of skin cancer. There's drugs called bisphosphonates that can strengthen the bones as well. So if you do have the beginnings of osteoporosis, then there are some things we can offer to help, but it starts with lifestyle changes. If your sex drive or erectile dysfunction is a problem, we can't do anything to give you your sex drive back. We can't replace your testosterone because your testosterone is down for a reason, and that's what's controlling your cancer. But there are other ways of getting aroused, there are other ways of enjoying sex, etc. And psychosexual counsellors, your urology team, etc. will be able to help. There are various things we can offer to help that. In terms of hot flushes, so the hot flush is an interesting one. We know it happens because of the hormone therapy, but we also know there are some things that can trigger them. The first thing I'd say if somebody was troubled with hot flushes is keep a diary for a few weeks. Keep a diary of what you're eating, what you're drinking, what you're feeling, what you're doing, and see whether there's anything in those groups that are triggering your hot flushes. Now, has anyone done that, or has anyone got any ideas what might make flushes worse?
Humidity.
Yeah, definitely. So your environment. So, you know, and actually sometimes it can be extreme. So humidity definitely, but sometimes coldness can also trigger them. Anything else?
Waking up at night.
Waking up, yeah. So, and that's a very insightful comment actually. Lots of men come to me and say, I get hot flushes 5 times a night. And then we say, well, okay, are the flushes waking you up? No, I get up to pee, and because I'm awake, I then have a flush. So yeah, definitely. Being disturbed at night can often trigger a flush. I always say, if you enjoy it, it probably causes a flush. So caffeine, alcohol, both those things can definitely make you flush. Alcohol particularly, even if you have a drink in the evening, it can trigger flushes during the night, even the next day. Another biggie is stress. Lots of people notice that if they're stressed or worried or out of kilter, then the flushes tend to be worse. I always think, you know, when men are sat outside my room waiting to come in to find out their PSA, 9 times out of 10 I come out and the flannel's out because the stress is causing a flush. So when we look at fixes for flushes, the first thing you can do is find your triggers and avoid them. So if you know that alcohol or caffeine, for example, causes a flush, then you can make a decision about whether you want to stop it. Stress is difficult though, because if you start worrying about being stressed, it makes you stressed. So, you know, how do you break that cycle? A really nice way of doing it is to learn abdominal breathing, and that's breathing exercises that really expand your chest, and you go in through the nose, out through the mouth, and you do breathing cycles. And if you feel, sometimes you can feel the flush starting in the head with the tingles or the chest, and if you do those breathing exercises, and if you practice doing them, then sometimes that can be a really great way. Any relaxation, exercise, meditation, breathing, acupuncture, anything like that can be really helpful. And also their medications. So some people like herbal remedies, things like red clover, evening primrose. The evidence is sketchy around those, but some people find them helpful. So it can be worth a try. But there is some evidence around a drug called medroxyprogesterone. And I think about 75% of men in the studies found some relief, so it reduced the severity and frequency. And I don't know whether it's available here or not. I don't know if any of you, Megace is another name. But that can be helpful. So again, it's something, talk to your health professional about it, and that might be an issue as well. If you flush at night, anything to keep if your head flushes, so some people start flushing here, and some people go down up, some people go up down, some people in the middle out. But if you're a head flusher, keep something on your pillow to keep your head cool can be really helpful. We have something in the UK called a chillo pillow. For the breast enlargement, someone over there talked about that. There's a drug called tamoxifen which can help, but also sometimes radiotherapy to the breast before you start treatment can help. Otherwise, things like binding, camouflage. And then your cognitive changes, so that's things like your memory, etc., and fatigue. We know exercise is great for fatigue. Again, another plug for exercise, but things like relaxation, breathing exercises, and sleep hygiene. So sleep disturbances can be quite common. So things like avoiding tablets and computers at night, having your wind-down routine, a cool shower, etc., reduce the lights, reduce stimulation at night can all be really useful. So that's my fix-it box, which is sometimes what people want. But fixes often don't solve the problem, and I think, hot flushes are a big example of that, and any kind of sex or libido issues are definitely a big problem with that. If somebody comes with issues with their libido or sex, I think traditionally it's been like, oh, quick, let's get a tablet, let's get a pump, an injection, let's do something about it, whereas actually what we need to do is think about how we're going to manage this, because what we're looking at is change. We're looking at a treatment which changes your life, and you can fight it, or we can learn ways to adapt and to move through it and to find a new normal, a good way of living. And I say fixes don't solve the problem, because if it was that easy, we'd all be out of a job and we could just give you a leaflet and you could go home and do it. So I think as health professionals, what you should expect is somebody to be looking for the cues. So are you okay? Yeah, it's not enough. We'd be looking to see whether there was anything else going on, to ask the questions. Too often we don't ask the questions because we're scared of the answer, because we're humans as well. And if we don't know the answer, if we don't know what to do about something, as a health professional, it's really hard. So sometimes we just don't ask because we're scared, or we haven't got time. Acknowledge, and that's just about, it's really difficult. Sometimes I think, the elephant in the room is a lot of the side effects of hormone therapy are the same things that women go through as menopause. And that's emasculating, it's female symptoms. So sometimes acknowledging that, I said, it's a tough treatment. It's got lots of repercussions. Some people go through it beautifully with no problems at all, but if you are struggling with it, it's really important to acknowledge that that's the case. I think just listen to people's experiences, and I think groups like this are amazing, because what you can do is speak to other people that are going through it and get tips from them, and also just there's company. Isn't it great to know that you're not the only one going through it, and you'll meet somebody that's been on it for 5 years, 10 years and is still living great, which is a really good thing to hear. I don't know whether it's a little bit too tree-huggy, but allow space for grieving. I just think it's important to acknowledge there's a loss. It's difficult. And if you're on a treatment for life, yes, you're here, and that's a fantastic way of looking at it. But, there is a trade-off, and sometimes you're trading a bit of quality of life. So why not, admit that and talk about it. For your health professional should it also help you assess the impact. So, what's hell on earth for one man might be okay for someone else. And it's the impact that matters, because none of these things, apart from the metabolic changes, are dangerous in themselves. It's about how it impacts you. And then this is an important thing. Somebody should help you adapt, accept, a little bit of problem solving if necessary, but definitely look about how you're going to move forward. And I think groups like this and seminars, etc., are a fantastic way of doing that, because you get that peer support. So this is something that I've set up in London, in quite a few. We've started lots of places all over the country do it now. I call it staying healthy on hormones, just because I like illustration and it sounds good. But call it what you like. But it's basically we run a day event for anyone that's starting on hormone therapy. Is invited. We say come along, hear about hormone therapy, and we go right back to the beginning. We talk about the first session. It runs for the best part of 2 hours. We've extended it now, and we talk about what's cancer. You think, well, don't be ridiculous, we've all got cancer, why would we need to know that? But for lots of people, they're not actually sure what cancer is, what does it actually mean, why does it happen? And what the humbling thing for me is the first time I ran this was a room full of men that I'd looked after, I'd given all the information to one-to-one, were asking me questions, and I thought, oh my God, they haven't heard anything I've said because it was in the wrong time. So we talk about what's cancer, role of testosterone, role of androgen deprivation therapy, side effects, and we do lots of group work on that. Then we talk about things like finance, we talk about diet, we talk about exercise. We have lots of very interactive sessions on good exercise habits. One of my oncology colleagues comes and talks about what happens after hormone therapy. So if you're on long-term hormone therapy, what happens when it doesn't work as well? What about the other treatments? What can I expect? What does the future hold? Which I think is incredibly important, because the worst thing is if your hormone therapy stops working, you need to know there's something else there. Otherwise, it's very anxiety producing. And then we stop. Ends it with relaxation and stress management. When one of our therapists comes and does a lovely relaxation exercise with some aromatherapy. So I think we've had about 450 men through this and about 120 partners, and every one of them fills an evaluation out. It's very well evaluated, but the really important question for me at the end is, would you recommend this to any other men? And we've got 100% yes, I would recommend it. And most people think it's an incredibly important part of their journey to get this information up front. It goes back to what I said at the beginning about being proactive. Don't wait for problems to start. Let's head them off before they start and at least warn you about it. So when it does happen, you're not as anxious about it and you know what to do. So if you're on androgen deprivation therapy or hormone therapy and living well, there are some things you can do to reduce your long-term risk: healthy diet, exercise, stop smoking, moderate your alcohol. I think work with your team is really important. It's a partnership, and it's important that everybody understands that. I know you do, I'm talking about the other side. And it's really important because that will also stand you instead for good at other treatments. What we know now is optimising now means that you'll be as fit as you can be for any other treatments that come in the future. And there's some other general principles that people have found really helpful. Really take some time to talk about what's happened. And I'm preaching to the choir here because you guys are already doing that because you're in this group. But it's really important to talk about what's happened and spend some time talking about the process that got you to where you are. Definitely think about the impact and think about how you can adapt to the changes that have happened rather than try to fight them. And definitely things like techniques like relaxation and stress management can be incredibly important. Just in case I haven't mentioned it before, exercise is really important as well. Take home message. I love group seminars. I think they're awesome and I definitely think they can help. And absolutely ask about fixes, but just think about the other things as well, because a fix without some thought about adaptation to change and acceptance, etc., is never going to be as good. So I guess my question to you would be, I've talked a lot about what my patients have said if they've been their needs. I've talked about some of the literature and what the needs are. Is there anyone that has got anything that we've missed in terms of unmet needs? Does it look like a fairly comprehensive list?
I said I've missed most of it.
Brilliant.
You don't have that yet.
So for me, I guess what I find quite difficult has been the kind of existential concerns, and definitely reaching men that won't come to events like this, for example. As I said before, we serve in South East London a fairly deprived community. There's lots of issues with health literacy, general literacy, lots of socialisation, lots of poverty, etc. It's a mixed community. We've also got lots of richness as well, but that's the challenges. So I just want to tell you a little bit about this. We were very honoured. We had a patient leave us some money, quite a substantial amount of money, and he wanted us to think about a project which would target men with advanced prostate cancer or men on hormone therapy with a focus on palliative care. Now, palliative care, people tend to think about care of people dying, but actually palliative care is about managing symptoms, and palliative care is about quality of life. And that really resonated with me, and we thought, okay, what can we do with this? Because we had to bid for it. So we had a focus group with some patients and some staff, and we said to them, if we had this money, what would you want us to do with it? What could we offer which would improve your quality of life above and beyond what we do already? What do you think other people would want? Where could we provide it, etc.? And we got some really lovely information. So the idea was we'd do healthy hormones as a kind of spine, and then we'd offer other things along time. And some of the things people said is they wanted some days out. They said they wanted to get away and just spend some time with other people with prostate cancer. Some wanted to sing, we had golf, we had dragon boat racing. I think that was my idea, but I keep putting it in there. And then we also had some more serious things around legal matters, advanced care planning, symptom management. Grave talks are they also call them death cafes. They're basically groups that are set up for the general public, and a death cafe is somewhere you can come and talk about all matters pertaining to death and dying. It's not a morbid thing, it's just about opening up the conversation and so that everyone's more open about it. And it resonated a lot with a few national campaigns about trying to get the general public more engaged with those sort of thoughts. So from that, we set up something we called the Advanced Prostate Cancer Club. And it's there to provide support, information and activities. And the idea was that we ran a lovely support group at Guy's and St Thomas's, but some people don't want to come to support groups. Some people find the idea of sitting around and talking a little bit too artificial, and some people love them, but it's about that flexibility. So we thought, let's see if we can tag support along to something else so that it becomes more organic and natural. So this is what we've done so far. We're a year in at the moment. So I've got a support worker working with me who's been awesome, a little Italian woman who's like a pocket rocket and you can't say no to her. She's fabulous. We've run 5 healthy hormones. We've had 4 days out. So we've gone to a place called Hever Castle in Kent, which is a beautiful old castle from the 13th century. We've been to Kew Gardens. We've been to a palace called Elton Palace. We've had 3 art courses so far. So some of our members said they wanted to do something a bit more creative. So we've a local gallery is set up a set of 8 lessons, and they've produced some beautiful art from that. Absolutely amazing. We've got a walking group that goes around one of our parks, and that's, I think, the walking group has been really special. So it's gone from 2 up to about 20 people, and they meet at 10 o'clock. They do a lap of the park, and then they take route in the cafe, and they drink coffee and they chat, and it's become a very organic group, which has been absolutely lovely, and a lot of our members have got a vast amount of support from it. We've got a choir, and I laugh because I can't sing, and it's brilliant. Do any of you sing in groups? Fabulous. It's the most uplifting thing. It really is. We do it in the cancer centre. We sound like a bag of strangled cats, and we don't care. It just feels fantastic. We've had a lunch social, we've had a couple of grave talks, and we're just about to have a Look Good Feel Better, which is a pampering session for men. So it's a charity that bring in products and barbers, and they do an afternoon of pampering. And right at the beginning, we were told, men don't like groups, men won't come for pampering, men won't do this. Absolute rubbish. We've had amazing engagement. It's been really great. But most importantly for me, I've got a few patients that have been really hard to reach. They spend a lot of time phoning, and it's been really hard to get them involved in anything, but they have engaged with this beautifully. One of our patients, sadly, is now dying, but without getting too emotional, he spent the last 9 months of his life going and doing things where he's been virtually housebound because he's got no friends. And he's at home at the moment with cards from the group, and people are visiting him, and it's made a massive difference to his life. And these are some of the comments we've had. I'll let you read them through, but we've started collecting some proper data so we can evaluate it. And some of the themes coming through are that members have been feeling more active, less anxious, more able to socialise, and much more supported emotionally. And this is peer support. This is people taking control and doing it for themselves. The money will run out, so we set up a fundraising page, and we were going to arrange some events, and I sent it out to the group, and I just said, just to let you know, we've put this link up. If you've got any fundraising ideas, let me know. And within 2 weeks, we've raised nearly £2,000, and that's just from group members giving us money because they don't want the group to finish, which is, I think, is incredible. One of the reasons we've got the highest rate of incidence of prostate cancer is we've also got an incredibly high number of men from African and Caribbean backgrounds in our community. And black men, I'm sure you're aware of, but they're twice as likely to get prostate cancer as white men. In the UK, 1 in 8 white men and 1 in 4 black men get prostate cancer. So it's incredibly important to me that we reach this group. So we had a focus group with black men, and we said to them, this is what we've done, what do you think, would you come to it? And the resounding from our group was no, we wouldn't. We want something that's a bit more active. I don't want to go to something that's support or cancer related, but I will go to an exercise club. So now we're setting up an exercise club for men on hormone therapy to try and engage people at their request. So we're hoping that that will improve our reach a little bit better. So I'll sum up. Empowerment is really important. I'm aware that I'm talking probably to a fairly empowered group at the moment, but I think it's really important in terms of helping us to help ourselves. But my job is also to reach the disempowered to help them help themselves as well. So hormone therapy is a foundation treatment, so for me it's incredibly important to get that right, and lots of my time is focused on making sure that we are addressing some of the quality of life issues. If that's not happening for you, then maybe the message would be to empower yourself to make sure it does, either from yourselves or from your health professionals. There's lots of evidence around the importance of exercise, both in terms of psychological and physical well-being. Seminars and groups are incredibly empowering, as you know, and I definitely commend those. I think we should all be better, and this has nothing to do with advanced prostate cancer. I think generally much better about thinking about advanced care planning wills, and just say spread the word on that, just talk about it is really important. But I suppose my big thing is I'm not the expert, and we're not the experts, you are, because you're the people living with it. And it's absolutely imperative that any interventions have to be based on data from you and planned with you. And we try really hard to make sure that everything we do is planned and involved with men and their families. So I'm just going to finish with some examples. So I call this Quality of Life in Action in South London. If you know London, you might say South London's got no quality of life anyway, but I beg to differ, having lived there for 25 years. So this is some of our patients. So at the top is Gary. Gary was diagnosed in 2011 and took up exercise. And Gary went to the Oncology Olympics 2 years ago, where he got medals, which he's really proud of. And he's now trying to bring the Olympics to the UK as well. And he's an absolute inspiration. He's an incredible guy. Mark at the bottom is one of our local GPs who was diagnosed with advanced prostate cancer, and he's now working with us in research and also just completed a bike ride to Liège. Lee in the middle, Lee's our superstar. Lee used to be a drummer with Uriah Heep and Black Sabbath. And he has just spent a lot of time battling Ozzy Osbourne to get his platinum records back, and he's just got them. So for me, that's about quality of life. And he's also trying to make a documentary about his life. He's actually now terminally ill, but it's what he's trying to do while he still can. And that's just pictures of Lee there in his Uriah Heep and Black Sabbath days. And this is hot off the press. This is from the 14th of October. This is one of my patients, Rex. So Rex got his first album deal in August. He's 81. He's a musician, Afrobeat musician. And he's just got his first record deal, and his album's now out. And one of his tracks is called My Louisa. And he's so cute. So it's on Spotify if you want to look at it. He's so lovely. So I think for me that's just an illustration that it's really important for us to remember that quality of life is so important, and all these people for me are absolute inspirations. So that's definitely it from me, but I am more than happy to answer any questions on advanced prostate cancer or anything else if you've got any.
Could I just ask a question, please, under medications?
Yeah, please do.
I've been on hormone treatment for about 10 years.
Yeah.
And about 6 months ago, they put me on Zytex.
Zytiga?
Yeah.
Yep.
They also put me on prednisone. Mm-hmm. I'm having far more trouble with the prednisone, which is supposed to help the side effects of the Zytex.
Yeah, steroids are tough.
You have the answers?
Yeah. So Zytiga abiraterone is the other name for that, and it's one of our new treatments. On that infographic I showed you, it's one of the new ones that come along. Do you remember at the beginning I said that testosterone is made by the testes and a tiny bit is made by the adrenals on top of the kidneys? Zytiga affects the production of the testosterone in the adrenal glands, but it also knocks out some of the steroid production, which can give you bad side effects. So you give steroids with it to put the balance back in. problem is steroids can sometimes send you the other way and cause things like lack of sleep, weight gain, swelling, etc. So what particularly are you troubled with?
All those.
All of the above.
One recently, and I think it's the prednisone, I'm not saying it right, is blurred vision. And I looked on Google, as you do, and
Yeah.
it's one of the side effects.
How often are you seeing your doctor at the moment, or nurse?
Sorry?
How often are you seeing your doctor or nurse at the moment?
Oh, too often. About every 3 or 4 weeks.
Okay, so
And I go to the hospital every 6 weeks.
Okay, so when do you pick up your script? Is it every 6 weeks?
Yeah.
It might be worth talking to them because you can sometimes lower the dose and you can switch to a different steroid. So it might be worth telling them that you're struggling with the side effects and they might be able to tweak it a little bit. That you kind of have to take them because without them it can be a lot worse, but there can be some adjustments made. So I would definitely talk to them about it.
Somebody suggested acupuncture might help. Have you had any experience?
I think with all these things, if it were me, I'd try it because you've got nothing to lose. Are you still having any treatment now, or was it radiotherapy and nothing else?
I had the 35-day treatment for 5 or 6 weeks or whatever. I had none since.
Okay. And do they think that the pain is due to the radiotherapy?
Yes, they say it's nerve pain.
Yeah. Yeah. Radiotherapy, as you'll know, has changed a lot over 30 years. Our ability to bend and conform the beams is improved a lot. But 30 years ago, they would have taken quite a wide field. So that does sound like it right. I don't see it's worth a try. Yeah, absolutely. And there's definitely it's becoming a lot more mainstream now.
Immunotherapy,
Yes.
does it work?
In the UK, there's still trials going on. So in lots of cancers, lung, kidney, etc., immunotherapy has been shown... Are you okay with hearing me? I've just moved away from the mic here. It's been shown to be really effective, but we've not really got there with prostate yet. But there was a drug called... I've forgotten the name of it, begins with O. It's just getting its license now, but it's only for certain genetic mutations. So to get the drug, you have to be tested for a certain genetic mutation, and if you've got it, it can be helpful. But if you've not got that mutation, it doesn't work. So having said that, there are lots of trials going on. There's a couple called Triton, there's one called Neptune's. Some really big trials trying to answer that question, will immunotherapy work for prostate cancer? I think the answer probably is quite possibly it will, we're just not quite there yet. So I would doubt whether it's funded at the moment, but it'd be more likely to be available in terms of a clinical trial. So what the future probably holds is that when you get diagnosed, you'll get your genetic profile of your tumour, and then you will be offered a treatment which we know will work for that particular mutation or genetic makeup. So it will be a lot more targeted. So rather than everybody getting the same thing and it may or may not work, we'll be able to target your treatment depending on the type of cancer it is. That looks like the way it's going. Whether or not it's funded is, of course, another question.
I've got Parkinson's as well. I can't tell what is right and what is wrong between the mix, right?
So in terms of the symptoms you're getting, it's difficult to know what's causing what. So prostate cancer tends to affect men as they get a bit older. I mean, we have lots of young patients as well. And, you know, part of getting older is we do tend to have other health conditions as well. And sometimes it can be really confusing. What we do is we've got a service for over 65s, although they will take people younger as well. And we just call it optimisation. So they'll see people and just try to optimise the other conditions as well so that we can treat the cancer better. But quite often we are in a position, particularly, you know, things like fatigue, for example. Yes, it could be hormone therapy, but it could be Parkinson's, it could be a lot of things. A lot of our symptoms of treatment and of the disease are very non-specific. And I guess the art, along with the science, is trying to sort of tease out which is which, and sometimes we don't know. Sometimes, you know, it could be either. And that's why sometimes going back to a more holistic approach, and instead of wondering why, just like, okay, what can we do about this? You know, how can we, yeah. Because I think sometimes we can become siloed in, you know, I'm looking after this bit and I'm not looking at anything else, where actually, you know, your prostate is attached to the rest of you. So, you know, it's the whole person we need to be looking after, and whatever the cause, then, you know, we need to be looking at that. Okay. Oh, I'm very, very grateful for your attention, and thank you again for inviting me. It's been an absolute pleasure. Thank you very much.